Well, I'm thrilled to be here talking to you all today, and I appreciate your coming out on a Saturday to spend time thinking about melanoma. This is something that I've been passionate about for a number of years, and I actually picked this field in part because when I finished my training in 2009, there really wasn't a lot we could do for melanoma patients, and I figured that was a place that I wanted to work. I wanted to make a difference, and I'm thrilled to say that we're in the middle of a true renaissance in melanoma. We're watching this survival go up and up and up, and it is one of the biggest thrills that I could imagine. So you've heard a lot of the other speakers talk about the fact that melanoma incidence is increasing a lot because our sun habits have declined over the years. And the population that I am the most interested in are these folks that have successful surgery from somebody like Dr. Fleming, who's able to take out all of that melanoma and the potentially involved lymph nodes, and yet they relapse. And what I'm showing here is the long-term survivorship at longer than 10 years, and in some of these populations, those long-term survivorships have been as low as 15 to 30%, despite good surgery. And so obviously we need to do something for those folks that are at risk. So why is this important? Well, when a surgery is done, they take out what's clinically evident. They take out what they can see, and they can take out the reasonable lymph node area that's involved with the cancer. The problem is this is sometimes the tip of the iceberg. And these are calculations done by scientists at Merck who I've been carefully working with, that there may be as many as 1 million or more cancer cells left behind at the time of one of those surgeries. We can't see them. Our scans are pretty good at getting down to about 6 millimeters, so the size of a pencil eraser. When we do a CT scan, that's about the limit of what we can detect. So there may be tumor here left behind after a good surgery. Where's this distributed? Well, we've done careful studies over the years in many of our previous adjuvant trials, where we've looked at the patients who eventually go on and relapse from their melanoma. Well, half the time, approximately, it's a regional relapse. Like the slide Dr. Fleming showed earlier, with all those spots on the skin, that's a melanoma that comes back in an area that had had a surgery. What's troubling is we see a lot of distant relapses, and that's what makes this cancer so deadly. It can go to brain, it can go to bone, it can go to lung, it can go to liver. It's just about every organ that you could imagine that's at risk for experiencing a metastasis from it. So, adjuvant therapy, what's that all about? Adjuvant is really a fancy word for an insurance policy, right? So if you live in a high-risk flood area, for example, you're going to buy a lot of flood insurance. Well, if you're a high-risk melanoma patient, you want to buy some insurance to prevent a relapse, and that's the whole idea behind what we do. We have been researching this idea for a long time, and I'm going to go through some of the history today. Many of these trials are now completed, and they include interferon, pegylated interferon, both FDA approved for the use in adjuvant melanoma. Biochemotherapy, which is something that is fading to some degree in use, had a brief interest from a trial published which began in 2008. Multiple vaccine studies have been done, and so far have been disappointing. We haven't had a really good vaccine trial yet in adjuvant melanoma, and then the one that has really generated the buzz recently is the ipilimumab versus placebo trial, and this led to an FDA approval of ipilimumab just last year. The pending list is bigger, and so obviously this is an intense area of research. We want to prevent all of the possible melanoma relapses, so there are many trials that are some of them completed, some of them ongoing in terms of their accrual. Their reporting is still a year or two away for many, and I'm going to talk about a few here today. So skiing. I'm from a very high-risk melanoma state. We do a lot of skiing in Utah, and I actually grew up ski racing. I was a kid in Oregon, and for years, these guys were kind of my idols. This is Phil and Steve Mayer. Many of you probably remember the 1984 Olympics when they, between the two of them, took home 3 medals. They're inspiring sort of ambassadors to the sport as well, and their success in 1984 actually parallels the work of John Kirkwood. So John Kirkwood is a medical oncologist like Dr. Vanderwald and myself, who really has been working in the field of immune therapy for perhaps longer than anyone. And he developed the clinical use of interferon for the prevention of stage 4 melanoma. Kind of a busy slide here. This is more of an actuarial table. This is what you'd be sitting down with your insurance agent to try and figure out whether your house is at risk for a flood or not, and how much insurance should you really buy. Well, to make a long story short, what we care about in melanoma is, first of all, relapses, and that's listed here as RFS, or relapse-free survival. That means how long after a surgery does a patient expect to wait before a relapse can occur. Overall survival, much more important. That is, how much time on the earth can we buy with a therapy for that particular patient? Now, when we look at thousands of cancer patients over time, and that's what these meta-analyses are here. They've pooled data from several different trials investigating interferon, and the data that I show here represents over 10,000 patients worth of data. It shows that interferon use for a year can delay a relapse from this cancer by 1 year. It also improves by about 10% the relative risk of relapse. This is where you have to do a little math. So if the relative risk of relapse for a patient or relative risk of death for a patient is approximately 30%, well, if you have a 10% relative risk reduction, that's only about a 3% improvement in your likelihood of being alive long term. So this therapy is important. It has a lot of impact, but the impact is modest. We would like to be seeing a lot more than just 3% overall survival benefit in our stage 3 patients, and we would like more than a year of delay in relapse. The other challenge to interferon, as many in the room may know, is it's not an easy drug to give. When we give this medication, it's actually a compound that's the same thing our bodies make when we get the flu, right? You get the flu, you don't want to eat, you feel like you have a fever. It's tough stuff, and imagine doing that for a year. Many of our patients who take interferon have a lot of those side effects that are persistent. They're tired, they miss days of work, and so it's a lot of work to get that 1 year of delay in relapse with interferon. So we're hopeful to do better, and this picture actually came from the Germantown commissary last night. I didn't expect to find ski racing fans in Tennessee, but this is a picture of Pepe Strobel. He won the Rookie of the Year award in 1995 for a very surprising finish in a World Cup downhill. And this poster is signed by Pepe, so he came to the German commissary where Val and I were sitting right next to this poster while we were at dinner. I have to admit, I violated a really important rule that my father handed down to me when I was growing up, and that is never eat anything bigger than your head. So, my ribs, about like that. So, also that year, and this is really where melanoma began to transform. So this man, Jim Allison, is a lab researcher. He is an immunologist, and he began work at UC Berkeley in the 80s to really understand how immune cells figure out whether or not to attack a foreigner. How do they decide what's a foreigner and what's a friend? Well, this molecule, CTLA4, is something that's called a checkpoint, and this is where your T cell, which is kind of like the Marines of your immune system, it's out there trying to attack cancer. But it's got an important checkpoint. It doesn't want to attack yourself, right? So there's a little feedback there that's basically telling the T cell to go away if the tumor, or hopefully not, the normal tissue is normal. So he did this work in the mid-90s where he showed this as a potential strategy to treat cancer, and it took a while for it to really get into patients. You can see the timelines of our drug development here are not as quick as we would like, but between 1996 and 2011, all of the basic science and clinical work ultimately led to a drug approval. Well, we had to test this in adjuvant care, so this was proven to help people with advanced cancer, those with tumors we could measure. But what about those patients that have had good surgery? How do we prevent their relapse? And so this trial was done where they compared a placebo to the active drug at a very, very high dose, much higher than what we actually give in stage 4 cancer. And like the interferon trial, this drug was capable of delaying relapses by about a year, and that's what this curve shows. These are patients alive without relapse on the y-axis, and on the x-axis we're going forward in time. And you can see that we're kind of moving that bar down the road by the use of this drug. We don't know yet whether or not this will make patients live longer. And part of the reason for that is that the drug is not free without adverse events. Patients can get pretty sick on this. They can get extremely bad diarrhea. Imagine 10 stools a day, barely able to keep up with the fluid going in as what's coming out. That can happen on this medication. And in fact, some other peculiar side effects can occur as a result of this. One being hypophysitis. That's kind of an unusual side effect. And to explain that more fully, this is your pituitary gland is basically the master and commander of all your body's hormones, right? It controls your testosterone, it controls your cortisol, your sugar-salt balance, your thyroid hormone. All those things really tie into that pituitary gland. Well, when it poops out and your immune system attacks it, you can get profoundly fatigued. You can feel just not yourself. You can get headaches. And it's sometimes hard to pick up. I actually had a patient in my clinic just this last week who's on my clinical trial on 10 per kilo, and he's a 65-year-old man who rides his bicycle 100 miles a day. We have a lot of kind of wild athletes in Utah. Well, he came in and complained that he could only ride his bike 20 miles a day. And so I got an MRI scan, and lo and behold, his pituitary gland was starting to suffer as a side effect from this drug. So it really is not free of trouble. Even more concerning is that in the conduct of this trial, 5 patients died. This is not a very big trial. And they died of side effects such as colitis, which I told you about, the very bad diarrhea, another patient with heart problems, and then finally another patient with Guillain-Barré syndrome, which is a disorder of the nervous system. So when you're kind of looking at melanoma in this category, the risk of death from melanoma is vastly higher than the risk of death from the drug that we're giving, but nevertheless, we need more safety and we need better drugs. So it did lead to an FDA approval of ipilimumab, and it has happened in the context of multiple FDA approvals of several drugs that you're going to hear more about from Dr. Vanderwall. It takes us a while to catch up, and the one that I want to key in on now is a drug called pembrolizumab. It has a very close cousin called nivolumab, and these drugs are targeting something that is called the PD-1 blockade. So very similar to CTLA-4, this is perhaps an even more tumor-specific marker. PD-1 really was discovered back in the 90s by this gentleman, Tasuku Hanjo. His real claim to fame is he's a terrific mouse immunologist. He makes knockout mice for just about everything involving the immune system, and I've actually received mice from him in our laboratories at the University of Utah. But they discovered it as something that's capable of interrupting that checkpoint, and the work of Arlene Sharp, Gordon Freeman described its function in cancer cell lines, and then ultimately Lei-Ping Cheng took this across the finish line with antibodies that ultimately led to treatments that we have for our patients today. I show you this because this is 2014 when the group of 4 scientists shared the Distinguished William Coley Award for Distinguished Research into Immunology, and that's the year we launched the trial that I'm going to tell you about. Also in that year in Sochi, Russia, Ted Ligety, one of our native Utahns, won a gold medal in the giant slalom, and Michaela Schifrin became one of the youngest skiers ever to win a slalom medal, and they're both still active ski racers today. Ted in particular is a wonderful ambassador to our sport. He's still very active in the Utah community. I haven't had the opportunity to ski with him yet, but someday I would love to. So PD-1 inhibitors in stage 4 cancer describe what we needed to know and how to do this in stage 3. So bear with me for a moment while I walk through this kind of busy slide. What we're trying to do in stage 3 is eradicate every last possible site of cancer. Well, one way we can figure out how long to treat a patient to achieve that goal is to see how long it took to get rid of tumors we can measure. So things that are bigger than a centimeter, for example, a lung tumor, we want to watch that thing go away over time. So these are patients receiving PD-1, and followed forward in weeks on this axis are patients that are doing well on therapy. Those are the arrows here. The little yellow triangles are the time at which we first see their tumor shrink. And that's exciting because it happens quickly. And we've both had the experience in our clinic where we'll see a patient with very significant volume of cancer look a lot better by 12 weeks. So this is about 3 months into therapy where we score very significant reductions. The red triangles are even more important. So that's when every last measurable spot of cancer in that patient is gone. And we can't see it on a scan, we can't detect it in their blood. And so we figured that it would require at least a year of this therapy to achieve that for those tumors we can't see. The other great thing about this drug is it's much safer. So what I just shared with you about ipilimumab, obviously this has a lot of side effects. When we've studied this in patients with stage 4 cancer, the likelihood of a significant side effect, and grade 3 or grade 4 really means that this is a side effect that's probably going to lead to hospitalization or a very serious health complication. That number is only about 12% on pembrolizumab. Ipilimumab, the number is probably closer to 40. So you can see how much safer this drug has become, and that's very important when you're considering the treatment of a patient who may be cured, right? We don't know that ahead of time, and so we want the safest possible drug in those folks. And that's what's led to this trial. So now we have a randomized study comparing pembrolizumab versus interferon or ipilimumab. I do need to update this slide. And it's sponsored by one of our national cooperative groups called the Southwest Oncology Group. And this is a study that's open here at West Cancer Center, which I'm thrilled about. We're looking at patients who are at high risk for relapse. So this table shows, basically based on the thickness of a tumor and the presence of lymph nodes, how likely that person is to relapse and sadly die of melanoma. It's some scary statistics, but you're looking at numbers here with 50 to 30% 5-year survival. Fortunately, these are improving, so this slide is very out of date. There is going to be a major update coming probably within the next couple of months that I think is going to show all of these numbers improving, which I honestly can't wait for. It's one of the more exciting things that's happening in our field. So the trial design is simple. We're going to compare patients treated with MK-3475, or pembrolizumab is what we call the drug, to an FDA-approved standard of care, which right now is either high-dose interferon or ipilimumab at 10 per kilo. So the patients who enter this will have a choice on the control arm between the high-dose interferon and ipilimumab. We want patients over the age of 18. We're working on getting this down into the younger population. Melanoma, as you heard earlier from Dr. Schwarzenberg, that these are sometimes involving children, and we need to actually study that group. The regulatory hurdles to get into the population is a little more difficult, which is why we're not there yet. But all these patients will have completely resected melanoma, and we have a few other criteria here that I want to point out. One is, surprisingly, we would be interested in having patients with HIV on this trial. You might think that because your immune system is not working well with this disorder that you may not respond to these very good immune drugs, but these patients have such good outcomes now with the good HIV therapy that we expect them to respond. So there really aren't a lot of exclusions to participation. Our objective is to prove that people can live longer, that's OS, and then of course we want to delay relapses, and that's our other measurement. Along with this, we do a lot of correlates, and what we really want to know ahead of time is, can we predict who's going to respond? Are there things about their immune system that are really going to tell us the answer is who needs the drug and who might not benefit? And that's what this portion of this slide is all about. The other thing that means a lot to me is how well are patients feeling while they're on the trial? And this is what we call patient-reported outcomes, or what is the average experience like? And we're surveying our patients when they come into clinic to say, how big are the side effects from the drug impacting their life, or how much is cancer impacting their life? And so we're getting multiple surveys sampled forward in time, and this research is being conducted by Sapna Patel, a collaborator and friend at MD Anderson. The other thing that we're doing with the study is we are banking every scan. So as you heard from Martin earlier, we don't know exactly what interval we should be scanning these patients. We may actually be over-scanning to some degree. And I'm hopeful that the image banking that we do may actually reduce the amount of imaging that we do for our patients over time. And we want to prove that that's a safe thing, so that's why we're banking all of these images. It's a big trial. It's probably over 1,300 patients that will be required to complete it. It takes a long time. Although we're beating this mark, we anticipated initially 3 years of accrual and probably 2 years of follow-up before we can report the results. These are the milestones that we expect, so I'm hopeful that I am going to have news by the fall or winter of 2018 as to whether or not this is working. So it's coming up actually quite quickly. And fortunately, we're doing quite well. So this map shows you all of the participating centers, including Memphis, that are giving patients to this trial. And our accrual rate, this began in the fall, so these are numbers in November, really took an uptick once we made an adjustment to add ipilimumab to the trial. And so we're actually about double the pace of accrual. I think it just tells you how important this is to the melanoma community and how much people want access to this trial. The decision of which drug to pick also has been an interesting thing that we're getting some live feedback on how patients see the world and how their physicians see the world. And that is the choice between high-dose interferon or ipilimumab. And what we're seeing so far is that after the amendment, there is a slight skewing towards ipilimumab use, but still a lot of people are opting for interferon. And I think it tells you that many times in medicine, we don't have a clear answer, and there are very strong opinions on either side of the fence as to whether interferon's a better drug or ipilimumab is a better drug. And this is where sitting down, if you are facing this decision with your oncologist, and I spend about an hour with my patients when I try to talk to them about making this choice, the pros and cons of each. And they have to decide before entering the trial, because if they are randomized to this, they have to know what they're going to do. So I'm going to close. Ski racing is an exciting sport. These are some other of my heroes. This is Herman Meyer. We called him as a kid the Herminator. This is Hannah Carney, who actually is my wife's cousin, and she won the first Olympic gold in freestyle in Vancouver. This is Lindsey Vonn. I think many know her name. She has been an absolutely dominant female skier on the World Cup scene, and this is Bodie Miller displaying some bizarre technique, as he often does, in a race at Park City. And with that, I'll just thank you for your attention. I thank Val and Ari for inviting me here to give this talk. And I look forward to our conversation that we'll have after the break. Thank you.